Show. I'm Greg Riccardi here with my co-host Dr. Richard Call and our special guest here, Dr. Doug Spiel. I know you guys want to talk about this this political doctor.
The spine turf wars.
The spine turf. Did you coin that phrase?
I did.
The spine turf.
And what do you think of that? That's a brilliant piece of marketing, right? The spine turf wars. You see, here's the thing. I'm a great student of history. Now, the Second World War was only called the Second World War because some guy said, listen, we have to give a name to this period of time. We can't just say there were like lots of battles. We're going to call it the Second World War. We're going to give it a time period. So they said, we're going to call this the Spine Turf Wars. We're going to give it a time period. And that's what we did.
There we go.
Well, there's a lot of turf wars going on right now.
Okay.
So I think Rich is basically pointing towards the turf wars going on with physicians.
Yeah.
Whereas physicians of different backgrounds are battling for the procedures on the same playing field. But it's not just going on with physicians, it's going on with companies that produce all the little doohickeys that we use. And 7 different companies can have 7 different doohickeys, and they go to the masses and they go to all the physicians and say, we want you to use our piece. So there's a lot of battles going on right now. Specifically in medicine, many of us trained in different backgrounds. I know Rich was an anesthesiologist. I was a radiologist about 15 years ago, and we both started performing endoscopic spine surgery. Different skill sets that brought us there, but we both learned many of the key points in order to surgerize patients and do it both safely and efficiently. And certain associations have opened their doors to us. The American Society of Interventional Pain Physicians produced the American Board of Interventional Pain Physicians, that allows people of different backgrounds still to get board certified and go on to learn those types of procedures. So the gray areas between the disciplines are blanching now with time. Certainly every subset of physician population wants to hold on to whatever procedures were inherently theirs. But the idea of what was inherently ours is now changing.
Correct. Technology does that.
Right. So is this so that you can keep performing the same type of surgery you've been all this time, and so does it boil down to a money thing?
Well, money's a part of it. Okay.
Right.
Of course, money plays a part in every aspect of our lives. There's no
right.
getting away from that. However, it's more than that. It's an issue of professional ego, professional jealousy, professional protectionism, and what happens and what has happened in the Spine Turf Wars, which people should go and read. There's a book now, published on Amazon. What they should do, when people read the book, they'll see that there was this sudden evolution of technology in spine. There was an improvement in imaging techniques so that people could see what was happening in the spine. And the guys who came from interventional radiology, like Doug, and interventional pain, like myself, we had these skills very well developed. So we were able to use this portable X-ray machine called a fluoroscopic C-arm and visualize the spine and put probes, needles, instruments and dissectors into and around the spine quickly, safely and effectively, much more so than a traditionally trained neurosurgeon or an orthopedic surgeon who did not receive training in fluoroscopic guidance and interpretation, which is the key component of this. And the example that I always use is look at cardiology. 25 years ago, when most people had a cardiac issue like yourself, Greg, they would go into hospital and they would have their chest cut open and they would have a bypass done by a cardiac surgeon. Today, if they need anything done, they have an interventional cardiologist place a little tube and place a stent. Well, that's what we do. That's exactly what we do on patients, and we get them in and out the same day. The neurosurgeons don't like it because it takes away their business. Now they're going to have to retrain. And some of them are. They're realizing that this is the way of the future. The orthopedic guys are going to have to retrain. Some of them are, because they realize this is the way of the future. But ultimately, all of this is better for patients. And, once you've started a good thing, it's not going to stop. And, I happened to be involved in a very high-profile public battle about these particular types of cases. But guess what? 10 years later, these outpatient minimally invasive fusions are the standard of care. Progress.
Well, we have a website, One Day Fusion, where I share it with actually an orthopedic surgeon friend of mine, and we can put minimally invasively fusion apparatus into the lumbar spine And aside from the pedicle screws, which I know you're very familiar with, little rods and screws in the back of the spine, placing the cage is done through an 8.5 millimeter cannula. And so with the addition...
And that's like the tube, right?
Little straw.
Right.
So with the addition of that little cage and some screws in the back, and the advent of what we have now is a type of anesthetic that'll last days and not hours, liposomal bupivacaine, we can really get these people out of the hospital within 24 hours.
Which is exactly what I was doing 10 years ago. Now, I'm not going to, there's no one here to pat myself on the back, so I'm going to pat myself, right? But I was and Doug will, is my witness here, I was the first doctor ever to perform an outpatient, minimally invasive spinal fusion. It was considered a combination of insane, revolutionary, groundbreaking, but it changed the face of medicine. And today, this is what is happening. And this sector, the minimally invasive spine sector, specifically the outpatient minimally invasive spine sector, is predicted for enormous growth. So, things have changed. The way that we treat people's back problems have changed.
Right.
For the better. Right? Nobody wants to have their back sliced from neck to sacrum. Nobody wants that. Okay?
Right.
And doctors like myself and Doug have the ability and the training and the expertise to do these cases. And, there are just going to be some guys who just are never going to accept that, but it's a fact of life.
Before the break, we were talking about the spine turf wars, and my question is, so what's going on with? Are the wars still, big and prevalent?
I can say, and I'm sure Doug will agree, and he'll have his own opinion. I can say that as a consequence of the high-profile nature and the fireworks that went off surrounding my case, that things have settled down a little bit. Because I think the realizations amongst the people who didn't quite understand the arena have settled in. That technology has changed. That people are getting better by having procedures done in a minimally invasive fashion. There are still, however, some what I would call sectogenarians of the medical community who don't quite understand, what's going on.
Right.
But they're going to be gone soon. So I think we've come through, I would say, the worst of it. And looking at things globally, I can tell you that I've been contacted by many groups of physicians from around the world asking for me to go out to their parts of the world and train them in these techniques. And I think it's been, for me, it's been a very heartwarming and reassuring thing to hear and to have and to be able to be a part of. To know that I was part of a group of guys in New Jersey that changed the face of spine medicine, because it wasn't just me, it was Doug, a couple of other guys who really were at the forefront of changing medicine for the better, and to provide better care for patients.
Greg, some of the procedures we do, there are analogous, similar, minimally open procedures that can be offered to patients. Certainly in the low back, we do a lot of endoscopic spine work, and there are forms of microdiscectomy that are relatively smaller incisions. Certain of the procedures that we do, there are no analogous open procedures. When we do endoscopic spine work in the cervical spine and the neck, we're making very small incisions, 5 or 6 millimeters, and we can remove just the herniated portion of the disc and leave the remaining disc in situ without affecting it. There is no analogous procedure open. They have to take out the entire disc and do a full fusion, known as an anterior cervical discectomy and fusion. Whereas endoscopically, you go home with one suture, one stitch, and maybe some glue, and you go home the same day.
Wow. So what's your typical case? Is it an injury, or is it just old age? What brings people to you typically?
It's mostly degenerative. 90 to 95% is degenerative, and within that we include patients or people who've been involved in car accidents who've had an acceleration of their degeneration. The majority of cases we treat are in the cervical, the neck, and lumbar region.
You see, I don't like the term degenerative, because I think degenerative presumes that we knew that there was no insult and time took effect. I think in many cases, many of these people, I feel, had some kind of an inciting injury that led to this.
Yeah, Doug's right. Yeah.
At some prior time.
Which they may or may not have been aware of.
I would agree with that, Rich.
Yeah. Right, gotcha. So And age-wise, you see them all over the place, or?
I've operated on teenagers and men and women in their 70s, near 80.
Mm-hmm.
Yeah. It's, and people ask that question about age. Pain does not discriminate age. People experience pain in their 20s and in their 80s.
Right.
And that's essentially what we're treating. So as physicians in this sector, people come in and they say, I have pain. Then their responsibility is to use our diagnostic tools, our eyes, hands, and our physical examination skills in conjunction with MRIs, CAT scans, X-rays, nerve conduction tests, to work out where exactly the pain is coming from, to map the pain. Once we've spotted where the issue is, we then use our skills in minimally invasive spine surgery to go in and to treat that part of the problem.
Mm-hmm.
And we do it specifically, and we do it safely, and we do it without the disruption of all of the muscles around the back, which is what the old-timers used to do.
Right, right. So, speaking of that machine you talked about, the C-arm?
C-arm.
Right? That's what they used with me as well.
Correct. It's a fluoroscopic C-arm. It's a mobile X-ray unit.
Right.
And it's one of the key components of this arena, not just in spine, but in cardiology, because what it does is it allows visualization of body structures that have been injected with contrast or bony structures, and it allows the individual physician or surgeon to perform the procedure in real time to know where the catheter probe instrument is going and where it needs to go. And Doug's training, Doug's an interventional radiologist, so he's the real expert on this.
Right, right.
Well, you know what it allows us to do? It allows us to see things in two planes because it rotates. So what orthogonal views allow you to see, you get to see left and right and front and back. So in a three-dimensional mind, you can take two-dimensional views and figure out in terms of where you are exactly.
Right.
Because you want to operate on the area of pathology.
Right. So just to give people at home in their cars, a visual of this, it literally is like a C, a big C,
Yeah.
right? And the bed that you're lying on is in the middle of the top and the bottom of the C, so to speak, right?
Yeah.
And that rotates circularly. And could you say it's like a line? I
Well, I
I've
guess
seen
the
it
opening of the C, there's a unit on the C that sends the electrons, and one of the units that sees the electrons.
Mm-hmm.
And so if the opening of the C was on the left patient, side of the left patient, you can rotate it 90 degrees so that now you're looking at from the sides of the patient. So
Right.
up and down or side to side. And those two dimensions are very important because that lets you locate a specific point in a three-dimensional world.
Mm-hmm. Yeah, so then while you're actually in the operation, in fact, I even saw it while they were putting the stent into the artery. You're actually, it's almost like you're watching TV. You're not even.
It's like watching a video game.
Right.
Now, by the way, that was a radiology procedure years ago,
Well,
before the cardiologist
exactly.
took that.
What's the difference between a radiology procedure and a?
Well, a lot of the procedures that are carried out using fluoroscopic guidance
Right.
started with interventional radiologists. And the funny thing in spine is that neurosurgeons and some of the orthopedic guys tried to hijack that and claim it as theirs, when a lot of these approaches were developed by interventional radiologists.
Mm-hmm.
So, that's kind of the hijacking and the sort of turf war bit that goes on. But at the end of the day, what it really comes down to is the proof of the pudding in the eating. Right? So you look essentially at who's doing the best job for the patients and who are getting better.